Good evening, everyone. I take this opportunity to welcome Dr. Deepanjan Mitra. He is having nearly 16 years of experience as an independent practitioner in Kolkata in nuclear medicine. He has done DNB nuclear medicine. He is presently a full-time consultant and is HOD of nuclear medicine and PET scan in North City Diagnostic Centre in North Kolkata. He had been previously working as an HOD of nuclear medicine in Amri Hospital, Kolkata. He has been ex-secretary of Society of Nuclear Medicine in India. He has been an executive member of Association of Nuclear Medicine Physicians in India. He had many journals and he have been doing many peer reviews of medicine and nuclear medicine. He had contributed chapters in different books in nuclear medicine topic. In the presence of our august audience and Dr. Soumya Mondal, Secretary, and our President, Dr. Prasanna Kumar Mishra, I welcome him in this academic event. I asked Dr. Prasanna Kumar Mishra to say something about it.
Yeah, this has been our endeavor for last 5-6 months to do a quality educational class every month, and this is probably the 5th one of the series. And we look forward to learn more about the use of radionuclides in urology practice. The application has expanded now, and we look forward to learn a lot of things from Dr. Deepanjan. With this, I believe we should go ahead with Dr. Deepanjan. Only one housekeeping request. The people who are not speaking at the moment may put their microphone off so that there will be no disturbance from the whole topic. So thank you, Dr. Deepanjan, for accepting our invitation, and you can go ahead with your talk.
Soumya Mondal, sir. He has been practicing mainly in the North Kolkata, Deepanjan, sir. You may be very aloof from this part, but he is a very renowned practitioner in this part. Sir, please welcome him.
Yes. So, Dr. Deepanjan, please share your screen and go ahead with your talk.
Good evening, everybody. Is it visible now, my screen?
Yes, you are visible.
Yeah, you are visible, but not the screen.
My screen is not visible?
No,
One second,
I will put it up and reshare again.
Then Dr. Deepanjan shares his screen. Let me just say a thing. That this subject, we are choosing subject on the basis of requirement.
Yes, sir, it is visible.
Yeah, now it's visible.
Yes, sir, you are visible as well as your screen.
Of course, sir.
Yes.
But can you see the slides?
Yes, you are visible now, sir.
Okay.
Okay, let's move on with the present topic.
Good evening, everyone. And thank you so much, Dr. Shashi and Dr. Mishra, sir, and everyone for inviting me for this presentation. Basically, when we talk about nuclear imaging in renal diseases or nephrourology, we have conventional scans like DTPA, DMSA, and we also have PET scans, particularly in the context of prostate carcinoma, and of course, urothelial malignancies. But primarily, this lecture is designed to elaborate mostly on DTPA and DMSA. So before I go into the details of individual scans, I would like to tell a bit about what nuclear medicine is all about. It is a discipline of medicine that uses radiopharmaceuticals for diagnosis and treatment of diseases. Please carefully note that when we say, loosely we say isotopes, radionuclides, but then what we inject to the patient is a radiopharmaceuticals. So there are two words in it. One is radio and one is pharmaceuticals. Radio means the radionuclide, generally the technetium in this case, and the pharmaceuticals depends on which scan that we want to perform. And nuclear medicine is a specialty which has two distinct divisions. One is diagnostic, that is the gamma camera scans and PET scans, and therapeutics, that is, I believe all of you know about isotopic therapy, something like phosphorus therapy for bone metastasis, these days lutetium therapy for metastatic prostate carcinomas and all. So both together, the diagnostics and therapeutics together, the branch is renamed as theranostics these days. But why do we need nuclear medicine? Because conventionally, when we talk about diagnosing any disease, we think about radiological modalities like X-ray, ultrasound, CT scan, MR, etc. Now, all of those modalities use ionizing radiation or ultrasonic wave. So whatever we image is the structure of the organ or the pathology. But what happens is we all know that by the time the disease initiates in the body and it is manifested or clinically picked up, there is a lag time of diagnosis. So whenever there is a change in the physiological milieu of a cell, there is change in the handling of each isotope in those cellular structures. So if we use a specific radioisotope targeting a particular organ, for example, in this case, kidneys, and if there is change in the physiology, the isotopic handling by the target organ will be changed. And that is why the diagnosis through nuclear scans are much earlier than a structural diagnosis like CT or MR. This also gives functional parameters like you all know the GFR or split functions, etc. And as I mentioned, for example, we do a PSMA scan, we can also plan PSMA therapy, which is called as targeted therapy. Now, in nuclear medicine, there are different kinds of isotopes that we can use. Most commonly, what we use is a gamma emitting isotopes. The most common one is partechnetate or 99M Tc. The other one is what we use is the positron, that is positive electrons, or beta plus, which is used in PET scans. Now, alpha, beta, all these things are also used in nuclear medicine, but they are for therapeutic purposes, not in our scope of discussion today. Now, sir was asking, how do we get the isotopes? So if you look into this thing, this white and red box, this we in our department call generator. What is a generator? This is the source of the radioisotope. For example, the technetium, when it comes to our department, it comes as a molybdenum because this houses the molybdenum, that is the parent isotope. It decays into technetium every day, and every morning we bring out technetium depending upon how many number of cases we have. So as I mentioned that every Monday, generally every weekly, we receive this technetium source. Every day we plan how many cases we can perform. Because with this technetium, and this is the pharmaceutical. As you can see, these vials are pharmaceuticals. It can be DTPA, it can be EC, it can be MAG3, it can be MDP, it can be Sestamib, depending upon what we want to scan. So we tag technetium with the we call them cold kit. Cold kit means this vial, so that we finally get the radiopharmaceutical like 99M Tc DTPA, 99M Tc DMSA. So when it is 99M, it is the radioisotope, and DMSA DTPA is the pharmaceutical. So both together becomes a radiopharmaceuticals fit to be injected. If you look into this diagram, this is showing a heart to be imaged. Now this is the vial which is we are forming the radiopharmaceuticals. This is 99M Tc Sestamib. This diagram is designed for cardiac imaging. As you can see, this is the patient. When it is injected, the heart becomes radioactive. And when the patient lies down under a camera system, the rays, that is the gamma rays, are emitted from the target organ, in this case, the heart. The basic difference between radiological imaging and nuclear medicine imaging is such, herein the target organ is made radioactive. and the radiations are emitted from within patient's body to form an image. As you can see here, gradually there is an image of the heart which is being formed in the computer system or the scanner, and that is interpreted on the computer system by visual analysis and also by software analysis. Now, this is how the patient lies down in a camera system. This is a gamma camera machine. A lot of people call this a SPECT, S-P-E-C-T, that is single photon. Single photon is gamma, emission computed tomography. These days, SPECT machine comes along with CT, that is called a SPECT CT. For example, if you do a bone scan and you do a CT simultaneously, so you get both anatomy and physiology together. So this is basic of how we image a patient. We prepare the radiopharmaceutical, then we inject the radiopharmaceutical, and we make the patient lie down under the camera system and then take images. Now, what are the different radionuclide studies in nephrology? So there are some bullet points. What is a renogram? What is a diuretic renogram? What is renal cortical imaging? What is DRCG? And what is GFR study? I've kept GFR study as a separate entity. I'll tell you why. Now, we all know what renogram is. And so these are the general indications that we get in our departments. One is the clinical questions are GFR. The scan is DTPA. And blood sampling method. So, I'm sorry. I will elaborate on it, but please remember, most of the time in clinical practice, we write DTPA GFR. We read DTPA GFR, but ideally, the DTPA GFR means not the scan, not the DTPA scan. DTPA scan and DTPA GFR studies are different things. DTPA scan, you all know, it is like injecting the isotope and looking at the renal drainage pattern. And then, of course, it gives a value of GFR on the scan, but it is never accurate. This has a lot of physics in it, so I'll not go into the details of it. But when we talk about DTPA GFR, it is a blood sample method. I'll elaborate on it. Now, the second indication is, of course, hydronephrotic kidney, whether obstructed or non-obstructed. We do a diuretic renogram. It can be DTPA, MAC3 or EC. MAC3 or EC are interchangeable. So MAC3 is basically an imported molecule. EC is indigenous to India. For renovascular hypertension, again, captopril renography or ACE inhibitor renography. Renal graft dysfunction, this same renogram. For the morphology or query scar, we do DMSA, and for VUR, what we do is DRCG. Now, how do we perform a renogram? If you can look into this diagram, we are injecting the radioisotopes into the peripheral vein. And as you can see here, the isotope is traversing to the kidneys, and the kidneys are seen. And then gradually, we take a video image of the KUB regions from 30 to 40 minutes, depending on the protocol that we are following. What we see, how the tracer is being picked up by the kidneys. Both the kidneys are taking the tracer simultaneously, or one kidney is taking the tracer a little late. How are they draining? What is the parenchymal transit or the corticomedullary transit? How is the tracers being excreted through ureters? And whether there is any obstruction or not. So, as I said, there are two basic radiopharmaceuticals that we use in renogram. One is DTPA and EC. We hardly do MAC3 these days in India because it is very expensive. And EC is just MAC3. So DTPA, as you know, it is a filtration agent. That's why we get GFR. And MAC3 is a tubular agent. That's why we get ERPF. Now, what are the major indications of MAC3? One is pediatric populations. We should stop doing DTPA scan for all pediatric patients. Take it from me because of the inherent characters of DTPA, because DTPA needs mature glomerulus. So the images of DTPA for a child is not as great. But if we do a MAC3 or an EC, the image is far, far better. So if you go to any institute like Holiday Institute or PGI, they just don't do DTPA. But we keep on getting referrals for DTPA for children. And the problem with a private institute is we cannot really change the prescription from DTPA to EC on our whims. There are so many issues, billing issues, people may think that we are charging them more, etc., etc. So the indications for EC is pediatric population and impaired renal function. If the creatinine is high and you want to see whether the system is obstructed or not, the best choice is EC. I'll tell you why. Look into these two scans. The upper scan, these are scans of the same patients. The upper scan is DTPA and the lower one is EC. The upper, because this was a patient, adult patient with raised creatinine level. If you look into the DTPA scan, the kidneys are seen, but the background, that is the surrounding tissues, are also taking up isotope. What does it mean? That the DTPA has not completely taken up by the kidneys. It is still in the blood pool. But if you look into the EC images, they're much sharper. So if the kidneys are seen better during our scan, naturally the confidence about the drainage will be more. That is why we always recommend. In fact, if you do not want GFR, because split functions will anyway, we will get from both the studies. If you do not want GFR, then EC is the best choice. In fact, a lot of centers do EC. Whenever you write a renogram, they will only do EC, because for obstruction versus non-obstructed system, EC is a far better scan. Look into this one. This is also the upper panel is a DTPA with a raised serum creatinine, and lower panel is an EC raised serum creatinine. If you see, the left kidney is seen much better. And please remember, when we do a DTPA or an EC scan, we image in a PA view setup. That is, the posteriorly we are seeing the kidneys. Unless we are dealing with an ectopic or a malrotated kidneys, wherein we follow an anterior posterior both images. Now, this is how a normal renogram, I know it is a very busy slide, but this is how you possibly, as a clinician, get to see a renographic film. Now, depending upon the centers and depending upon the systems, I mean, somebody has GE, someone has Siemens, so they give different kinds of images. So this is a GE system images. I'm sure a lot of you get this kind of images. And this generally comes from Siemens. We use a Siemens system. Now, what is a normal renogram? If you look into the first set of images, this is the perfusion phase, or angiographic phase. So if you see, the isotope is just reaching the kidneys and then gradually the kidneys are seen. So this is telling you what is the perfusion status of the kidneys. And this is the dynamic phase or the drainage phase of the kidney. If you look here, the kidneys are gradually seen and then they're gradually clearing. And these are pre-void and post-void images. Sometimes we take a delayed study. If you look into the curve, this is called renographic curve. Both the kidneys are clearing normally. And we also get some value like split function and GFR and split GFR. I think all of you know about it. Now, there are different protocols of doing diuretic redogram. Of course, it is a furosemide. This is the dose. Now, there are standard protocols of diuretic renogram is only three: F plus 20, F minus 15, and F0. F plus 20 means Lasix at 20th minute, minus 15 is give Lasix and start the scan after 15 minutes, and F0 is injection of pharmaceutical and Lasix simultaneously. But a lot of time we get requests like F8 and F10. Trust me, there is no written down protocol like this. There is no consensus. There is a consensus guideline how to do a renogram. These are not mentioned in the consensus guideline. There is only one textbook of nuclear medicine which has mentioned in their footnote about these protocols, and a lot of people have done it in their practice. That is why it is in vogue, but it is not a standard guideline. People want to give Lasix early because once you give Lasix, you have to do the study at least for 20 minutes. Now, if we give F plus 20, the study has to be at least 35 to 40 minutes. So people do not want to keep a patient for 40 minutes in their department because every department is busy. So they have tried, cutting the protocol to F8, injecting the Lasix at 8 minutes, and so that they can finish the study at 30 minutes. But There are all anecdotal papers. This is not in guidelines. I do not practice it. I don't do it ever, because I always follow the standard practice. If at all I have to cut down on the timing, then we will do F0, because there are many papers which say one protocol is better than the other, but with our clinical practice, hardly any. The advantage of F plus 20 in a non-operated native kidneys is such that sometimes you may not need to give Lasix. You see the clearance very nicely, so you may skip the Lasix. And F0 and F minus 15 are generally used in post-operative systems. Many papers had actually suggested that F minus 15 is superior to F0, but then it is too theoretical than the practical applications. Now, these are the consensus reports that I was mentioning. This was published in 1996, and till now, all nuclear medicine textbooks, and there has been no change in the how to do rhinography. I mean, this is the gospel of rhinography. So we follow consensus reports and consensus rhinography, and this was published as a separate issue of our journal, Journal of Nuclear Medicine. Now, coming to the clinical indications. One is, of course, whether the systems are obstructed, you know better. Generally, you get a patient with maybe with symptoms or no symptoms, incidental findings of hydronephrosis of one kidney. But the question is whether all systems are obstructed or whether it is a functional or organic obstruction, because there are so many other situations like megacalicosis, extrarenal pelvis, parapelvic cyst, etc. on USG. Now, if we look into this scan, for example, this patient had a right pelvic dilatation on USG. If you look here, this is the dynamic study. Both the kidneys are seen nicely in the initial frames, and gradually they're clearing normally, both sides. If you look into the rhinographic curve, they are non-obstructed. So this is a normal kidney. Pelvic dilatation does not always mean it is obstructed. Similarly, there is another patient which had a left hydronephrosis on USG. If you look here, if you look into this scan, if you see the left kidney is mildly enlarged from the right. If you see please always look the first two images of the rhinogram. Why? Because if you see the color gradient, this is for us, of course, this is much lighter, a little lighter than the right. Okay, so that means this is taking up little lesser stressor in the cortex than the right. So cortical, when we write, there is reduced parenchymal function. We mention it depending upon these images. Now, as you can see, the right kidney is gradually clearing, but the left kidney is not. If you look into the curve, the left kidney curve goes up and the right kidney curve goes down. And of course, all other parameters like GFR, split function, etc. These are like pre-void, then post-void, and delayed studies. So this is a left hydronephrosis, but this is an obstructed system. If we see in the video part of it, the dynamic part of it, you will see that as you can see, the left kidney is not clearing. Now, these are very commonly written in all textbooks, different kinds of curve. This is normal, non-obstructed. This is an obstructed type of curve. This is hypotonic. That means a functional stasis. The isotope was going up. I mean, there was a stasis, and the moment you give the diuresis at at 20th minute, you see the curve draining. And there are some equivocal type of curve, which is called as sluggish drainage. Most of the time, these are not truly PUGO. They appear in VUGO and sometimes in aberrant renal arteries. And this is a very interesting curve. If you see, this is like a hypotonic, that is non-obstructed. Then it is going up. It has a couple of names. Of course, type 4 curve, delayed decompensation. It has a name called Homsey's sign, HOMSY apostrophe S. This is seen in intermittent hydronephrosis and very commonly in VUR. Because if you look here, the curve is going down. That means the kidney is draining, but then it is again filling the pelvis. So generally in ipsilateral VUR, you will get to see this kind of curves. Now there is another patient with left hydronephrosis with parenchymal thinning. Now if you look into this scan, please look into the first set of images. The right kidney is seen brightly, but the left kidney is seen faintly. That means the left kidney is enlarged, but it is faintly taking up radioisotope. That means there is parenchymal dysfunction. Then if you follow it, you'll see the corticomedullary transit is delayed in comparison to the right. Thirdly, there is retention of tracer till the end of the study, and you get an obstructed curve. The red curve is going up. So it is a obstructed kidney with parenchymal dysfunctions. When we do a split function, you see the left function is 30 and the right function is 70. Similarly, another patient with hydronephrosis, you see there is no tracer uptake in the initial part of the study in the left kidney. So this is a non-functioning kidney because even till last frames like the pre-void, post-void and delay, there is no tracer uptake, but the right kidney is draining. So this is again a left hydronephrosis with no function. Now this is a 4-week-old baby, that means 1 month with an antenatal left hydronephrosis. This is an EC scan. See, look here. This is a DTP and this is an EC. Here, there is so much of background. That means the blood pool. You see the EC? It is absolutely clear. You are only seeing the kidneys. That is the reason we prefer doing EC scan whenever there is a question of reporting on obstruction. Now, if you see here, both the kidneys are seen very nicely. Now, gradually, if you follow, the right kidney is clearing, but the left kidney is, left kidney is clearing, but it is clearing sluggishly. Now, if you look here, the curve is going up. So you may say that this is an obstructed kidney because the curve is going up, but it is not really an obstructed even at this level. Why? Because I tell you, if you look here, first images, both the kidneys are taking up radioisotopes almost similarly. That means there is no cortical damage or there is no parenchymal dysfunction. Both the parenchymas are concentrating the radioisotopes well. If you see here, there is stasis of tracer in the dilated pelvic calyceal system, and with delayed images, it is gradually clearing. Here in the curve, it is firstly going down and then going up. This happens very commonly, as I told you, in VUR, but for child, if it is not a catheterized child, a lot of time what happens is the bladder gets filled up and bladder gives a back pressure. So the back pressure effect gives a false impression of the curve going up. So we, as nuclear medicine physicians, do not report a scan only looking at curves. We look all images, we see the videos, and we see parameters, what are the software values that are coming up for left and right, and then we make a consolidated opinion. Just looking at the curve may not be a correct assessment. Now, this is a common thing, like this is a antenatal hydronephrosis, wherein is, as you can see, this is a right kidney being obstructed. Here the curve is going up. This is post-operative, post-pyeloplasty. As you can see, both the kidneys are clearing nicely and both the curves are going down, going normally. So this is a pre-intervention and post-intervention. This is a very interesting paper. This was published around 2009, and I think it is one of the best papers on how to deal with a dilated pelvic calyceal system in children. This is basically, I think, this is a combination of members, like one neurosurgeon, pediatric neurosurgeon, one is a radiologist, one is a nuclear physician, and one is a pathologist. So, I mean, this is a very good paper. I suggest everyone to read this. This has all clinical questions and answers from each members of this group, and one conclusion, how to deal with each scenario. Now, coming to GFR. Of course, you know better than me that what is GFR is the earliest marker prior to renal failure. It goes down even before the creatinine rises. There are different modified formulas. Now, what is Gates GFR assessment? Now, this is the first paper. This is the Gates original paper, which was published in 1982. And then on, people are writing about GFR assessment by DTPA. Now, please remember, when we do DTPA scan, we always get a GFR value, but that GFR value is not what we call the Gates GFR. I mean, this GFR, DTPA GFR that we read in textbooks. Then what it is? There is a different method of assessing GFR by injecting isotope, by injecting the same DTPA to a patient. But in this case, there will be no scan. What happens is you inject radioisotope to patient and then you take out blood sample, like we take blood sample for other tests, at timed interval. May say 10 minutes and then 30 minutes and then 2 hours. And then we have different machines in which we will count the concentration of isotope at say 10 minutes and 30 minutes and then 2 hours, and by formulas we will generate the clearance. That will give us a GFR value. This is the ideal GFR assessment by DTPA. Unfortunately, none of the private nuclear medicine centers, including mine, have this instrument. Not that it is expensive, but just because the awareness is not there, people do not send for DTPA plasma sample method. The ideal terminology is DTPA by plasma sample method. So when I was in Bombay studying and in Tata and Jaslok and Hinduja, but then there was this is a standard practice at Jaslok that they do all GFR by plasma sample method. This is practiced even in all India institutes. But in clinical practice, even for donors, we keep getting DTPA GFR and everybody does a DTPA renal scan with the GFR that they get during the scanning. But please remember, GFR assessment during a DTPA renal scan is not accurate. If you read any DTPA report very carefully, you will always find a disclaimer written down as nota bene down there, that DTPA GFR assessment by DTPA scan is not accurate. So at least for exam purpose, if you get a question of DTPA GFR, you please write about plasma sample method in details. And of course, you can mention that we can get GFR in by doing a DTPA scan. The advantage of doing it in DTPA scan is you get the differential function or the split function, which we will not get in plasma sample method because you'll just get the total GFR. That is why in Jaslok Hospital, whenever they used to come for a GFR assessment, they used to do a plasma sample method by doing a GFR, and then they used to also do a DTPA scan to give you the split functions. This is a theory of DTPA. This is the reason that DTPA scanning GFR is not always accurate, because there is variable amount of protein binding of DTPA. Now, if you look into this scan and if you look into this scan, if you see this curve and if you see this curve, there is difference. The difference is effect of hydration. The one preparation, patient preparation, if it is needed for a DTPA scan, is hydration. Patient has to be well hydrated. Number two, if there has been any contrast study in recent past, the theory says there has to be minimum 10 days of delay. But in practicality, we have seen even 15 days post contrast study. Even if the creatinine value is normal, the background clearance is not nice. That is why we are very strict. If you have to do both DTPA and CECT, then please do the CT scan after the DTPA scan. That is the protocol. I mean, otherwise, if you do the CT, if it is a CECT, then if you do it first, then you have to wait for minimum 10 days, if not 2 weeks. Can I ask any resident? I mean, I'm just trying to be a little interactive now. Can anybody read this scan? What is this scan? What are the findings? Any resident? Anybody? I mean, even if you falter, no harm. Okay, so this is a DTPA scan. I hope I'm audible, right?
Yes, sir, you are very much audible.
I cannot get anybody. Okay, so this is a DTPA scan. If you see, this is the right kidney. and gradually draining, right? This is the urinary bladder. And if you look here, so the right kidney is draining, the bladder is seen. From here, if you see, the tracer is going across the left ureter, going up to the left renal pelvis. So in the pre-void and post-void study, you see there is a tracer in the left pelvis and ureter. So this is a non-functioning left kidney with a grade 5 VUR. So this tracer uptake is sometimes, if somebody is not careful, will say it is a significantly reduced parenchymal function of left kidney because it is seen in a delayed phase. But if you look carefully, the tracer is there is an ascent of tracer from the bladder. So it is a non-functioning system with a significant VUR. Now, these are hardly used these days, but just for the sake of completion, AC inhibitor renography, or you know that renal artery stenosis, whether it is really clinically relevant, we do a baseline DTPA or an AC scan, and we expect a normal looking curves here. And then post captopril, we get an obstructive curve in the affected kidney. So this is how we interpret renal artery stenosis or renovascular hypertension. I must be precise about it. So renal transplant evaluation, we hardly get these days. Acute rejection, generally the baseline is normal. And in follow-up scan, there is reduced perfusion and increased renal transit time. In ATM, the baseline scan itself is abnormal. See, what happens is in renal transplant program, if you want to use DTPA as one of the imaging modalities, then there has to be a baseline scan. Otherwise, if there is no baseline, even if you do it after 1 month or 2 months, it does not, nobody can tell you what is happening. So that is the main problem of using renogram these days with biopsies and so many other things. I think indications of DTPA in renal transplant evaluations been limited. One is, this is one post-transplant complications. If you can see here, this is the transplanted kidney in the iliac fossa, right? And as you can see, the kidneys are seen, but this around the kidney, there is a halo. There is a shadow. We call it photopenia. That means photon deficient area. Now, if you look into this is the photon deficient area in the arrow area. In delayed phase, you see there is tracer uptake in that photon deficient area. That means there is a collection, and the urine, the radioactive urine is actually going into that collection in delayed study. This is an urinoma. It is a post-transplant complication. So this is another scan. Now, if you see this, this is the right kidney, right? But where is the left kidney? The left kidney is down there. This is a ectopic kidney. And you know the indications of doing renogram in ectopic kidney. So this is a standard scan. But see, the kidney is very close to the bladder. So once the bladder is getting filled up, the kidneys are getting obscured. So it is very difficult to interpret an ectopic kidney without a catheter in situ. And if you look into this curve, this is the right kidney, normal eutopic kidney. If you look into the left kidney curve, it is going down sluggish, but then it is going up. Why it is going up? Because when we do a region of interest in this kidney, because we draw a region of interest around it, and that gives you the time activity curve. So that bladder activity is also getting included after 14 minutes because the bladder is filling up. So that isotope is getting included into our region of interest. That's why this rise is not because of obstruction. This is false. So anybody who is reporting the scan has to be very careful. If the kidney is in close proximity to the bladder, then there is something called bladder effect or reservoir effect. I mentioned previously as well. So what are the take-home message? Number one is no need of fasting. Good hydration is must. It does not have any harmful effect on renal function like contracity. There is no allergy of any nuclear medicine isotopes or pharmaceuticals. Radiation exposure is minimum. We always follow ALARA. Coming to the next topic, This is the UTI in children. Number one is, why should we image the children? Because of the risk of hypertension in future. DMSA and VUR studies. The first investigation is, of course, USG and DMSA. Some people do DMSA. There is a concept called acute DMSA, not very popular, not that we come across very frequently, in DMSA to rule out pyelonephritis. Now, as you can see, DMSA as an agent binds to the cortex or the parenchyma. So we inject the DMSA and wait for 3 hours, and then we take just PA, AP, and oblique views. That is LAO, left anterior oblique, left posterior oblique, right anterior oblique, and right posterior obliques. So 6 images, but then 3 images are also good. I mean, all posterior images like the PA, that is the posterior view, LPO and RPO, left posterior and right posterior. A lot of people do only three studies. That's also perfect. So this is how, this is the anterior image. So this is the right kidney, this is the left kidney, this is the posterior image. And what we see is the outline of the kidneys. And if there is any breakage in the outline, generally a scar appears like an wedge-shaped cortical defects. Here, as you can see, both the kidneys are seen nicely with nice cortical outline. Both of them are taking up isotopes. So good cortical function and no scar. This is our normal DMSA, as I was telling, the posterior views. This is the posterior image. This is one of the left posterior oblique, one is the right posterior. As you can see, nice cortical margins. So normal. This is a 6-year-old child with UTI. This is an acute DMSA. As you can see, the fuzzy outlines of the kidneys. These are always say, if you are doing a DMSA just after the UTI or during the UTI, you have to follow it up after, say, 3 to 6 months. So if you see here, the follow-up scan looks absolutely normal. So it was not the scar, it was just the pyelonephritic involvement. That is why whenever there is an UTI, we ask for a DMSA scan to be scheduled later. As you can see here, this is a child with bilateral VUR, and you see both the kidneys shape is abnormal and their irregular surface, wedge-shaped cortical defects, and left kidney function. This is anterior image, this is posterior image. Left kidney's function is preserved better. Right kidney's function is 18%. DMSA, when you talk about the cortical function, it is more accurate, even more accurate than DTP. If you do a DTP and DMSA, the parenchymal function or the cortical function, the best assessed on a DMSA scan. This is very common. Patient comes with an USG report without the native left kidney seen. As you can see, this is only right kidney in the posterior view. There is no left kidney. So it confirms the absence of one kidney or solitary kidney status. There is a multiple cysts in the kidney. In this case, only one kidney is seen, the other is not seen. So it is an MCKD. Unlike a PCKD patient, wherein you will see this kind of multiple round photon deficient areas, these are the cysts. So because MCKD is non-functioning, so it is MCKD. There are different congenital abnormalities that we come across in DMSA, and we are, generally we do, like this one is a horseshoe kidney. This is a cross-fused ectopia, as you can see. And this is just an ectopic kidney, left, right. This is the posterior image. So this left kidney is utopic and the right kidney is in lower abdomen. Coming to the last few slides, I think I showed you one scan previously. What is an indirect cystourethrogram? So there was a DTPA scan done. As you can see, the left kidney is clearing gradually and the bladder is being filled up. And from the bladder, if you see here, the ureter is seen. So it is a reflux. It is an indirect way of looking at reflux. This is DRCT is direct radionuclide cystourethrogram. And this is another way of doing DRCT, wherein what we do is we fill up the urinary bladder either through suprapubic puncture or through a Foley's catheter. So this is just the bladder. So we have filled up the bladder with radioisotopes and asked the patient to void in front of the camera. So we will take the video images of the urinary bladder while voiding. Here, this is just the filling phase. So these first images are taken while we are filling up the bladder. So this is the filling up the bladder, because at times some refluxes are picked up only during filling phase. Now, this is the voiding phase when the bladder is getting emptied. As you can see, this left kidney is seen. So it confirms, left viewer, that we have better images. As you can see here, I don't know whether I can, is it becoming bigger now? I mean, if you see here.
Yes, sir.
So is it now becoming bigger? No.
Yes, sir. Yes.
Yeah, it's becoming bigger.
Yes, sir.
So if you see here, this is the bladder and it is going up. So this is a reflux, but here it is very clear because it is a grade 2, grade 3 reflux. If you see here, these are all 3 different patients, and this grade 1, grade 2, grade 3 is not your standard grading. These are DRCG grading, not used much. So grade 1 means mild reflux, grade 2 means moderate reflux, and grade 3 means severe reflux, wherein you are seeing the pelvis. Now again a reader scan. Can anybody say what is this scan? I mean, these are different color code, black and white. This can be blue and red, whatever. This is a DTPA scan of a horseshoe kidney. Okay, so this is how we do a DTPA scan. As you can see, this is the left moiety, this is the right moiety, and gradually clearing. And we get the parameters. As you can see, both the kidneys, even if here you see both the moieties are clearing normally. So we got normal looking renographic curve and the values. A lot of people ask that since there is a nuclear ward in nuclear medicine, this is a very common question. Does imaging technology cause cancer? See, most of the nuclear studies, particularly DTPA, DMSA, and DRCG, we use very, very less radiation. But then CT scan, for example, does give a lot of radiation. PET scan does PET CT, because PET CT is a PET and CT, so it gives a lot of radiation. The major contributor being the CT. So this is there is a hypothesis called any radiation is harmful. This hypothesis is called as linear no threshold response model, LNT. That means it is linearly related. Any radiation, if the radiation is more, the chance of cancer is higher. No threshold. There is no threshold which is safe. So this model has been there for last 80 years in the context of medical physics and telling us that any radiation is harmful. But in 2016, in fact 2014, the world medical physics bodies have denounced this model because they could not prove this model as one. This has remained a hypothesis. And it has told us, it has many, theories and answers to it. The main point is medical radiation does not lead to cancer. This has created so much of radiophobia in people's mind that people have not taken the benefit of a radiological study, and a lot of diagnoses got delayed. So this is a very landmark paper, and even in Times of India in 2014, they published this news. This is to assure people that medical radiation, when used judiciously, for example, if anybody is coming and getting a CT scan done, is not something is advisable. But when it is needed, and if you are not getting done, but just because of the fear of a perceived future cancer, it is not advisable. So this, I think I end here, because the last question is anaphylaxis. None of nuclear medicine agents or radiopharmaceuticals cause anaphylaxis. In PET CT, if we use CT contrast, yes, of course, contrast may give rise to allergic reactions and anaphylaxis, but not DTPA, DMSA, and FTG. So I think this sums up, because rest of the slides about PSMA, I'll not go into the details of it. Thank you very much.
Nice presentation, sir. There are few questions which have been put up by our urologist. One is by Dr. Bimlesh Purkar. He is a renowned urologist practicing in Amri, Kolkata. What is the age of patient to demarcate between EC mag scan versus DTP? When will we demarcate between pediatric population and the DTP, as it is the same as the way we admit, or is it different between the EC mag scan and DTP? The age demarcation is different.
I didn't get the question actually. What did you say?
Sir, at what age we will prescribe for EC mag scan and at what age we'll ask for DTP scan?
Adult individuals, adults means these days, you know, the definition of pediatric population has also changed. I think it has gone up to 18 now. So adult individuals DTP is fine, but then any child at least 12 to 14 years, EC is far better. And to be very honest, all renogram, irrespective of age, if you want an information of obstructed versus non-obstructed, EC should be your choice. It is not about child or adult, but for children, of course, it is easy.
Sir, Dr. Anil Chomal sir has thank you for the reflex presentation, and he has few queries. Do you suggest F-15 diuresis renogram or F0 diuresis renogram in a moderate to huge hydronephrosis with suspected PUJ obstruction?
Theoretically speaking, a lot of papers have said that it is F-15, which is better, and that is how the guidelines say. Honestly speaking, it does not make much of a difference. And please remember, doing an F-15 study is very, very challenging. I tell you why. Number one is when you give Lasix, patient is well hydrated. We Lasix and we start the scan after 15 minutes of giving Lasix. Patients, it is very difficult for the patient to lie down for the required period of time. So what happens is a lot of time, patients, become restless even after 10 minutes. You need to do the renogram for at least 20 to 25 minutes, if not 30 minutes, for the kidneys to be seen and the draining and then proper clearance. F-15 becomes very challenging. Not that we don't do, we get a request, we do, but then it is, practically speaking, it is very difficult. I think F0 is the best.
Sir, another question is from Dr. Rishabh Dagra. Sir, for split function of duplex moiety kidneys, we get two different graphs with two different data sets. How to interpret these two graphs or data together?
First of all, interpretation of graph is very dubious, as I mentioned. We look in a very different way because graphs, sometimes we will see graphs going even for a sluggish drainage kidneys, post pyeloplasty graphs, the graph will go up, and we will not write it is obstructed. We will say it's sluggishly draining, because when we look into the video of the images, we see that the kidneys are clearing, but the curves, because there is a lot of physics into it, because we draw a region of interest, and that region of interest, the computer system generates the graphs. We do not draw that curve. Coming to duplex system, yes, when we will draw two ROIs, one for the upper moiety and the lower moiety. Depending upon whether one system is obstructed, naturally that obstructed moiety will show you a rising curve or obstructed curve, and the non-obstructed system will give you a normal looking curve. I don't know what exactly he is asking. The question, split function of we get two different graphs with two different data sets. How to interpret two graphs? That is because both the upper moiety function, I mean the split function, one is that data, upper and lower moiety, and two graphs, one is for upper moiety and the lower moiety. So that is it.
Sir, Dr. Navankur Ghosh has asked one what are the contraindications for DTPA or DMSA renal scan?
Hardly any, except if somebody has done a recent CECT study, then we cannot do. We have to defer it, not contraindications. And no, there is no contraindications after. Somebody has written, how should the curves be assessed for F0 or F plus 10 protocol in curve? Again, please remember there is no protocol called F plus 10 or F plus 8. So there are only three protocols, F0, F minus 50 and F plus 20 as per the consensus guideline. There are some textbooks which has mentioned about F plus 8 and F plus 10, but it is not in our Society of Nuclear Medicine has a set guideline. So tradition, standard, I mean, I don't do any F10 and F plus 8, and I always refuse. I mean, generally I speak to the consultant and get it changed to one of the protocols. So because there are postgraduate students, I would like to emphasize on it.
Sir, one question from me. What is the advantage of studying BUR with MCUG versus this isotopic scan, that is cystography?
Honestly, MCUG is far better, and you want to see it. But then, just because the radiation burden of MCUG is very high, particularly for follow-ups, no pediatrician or pediatric surgeon wants to do repeat MCUG. So they want to do DRCG. But doing DRCG scan is a very difficult task.
So how the radiation compares the MCUG versus radionuclide?
Sir, I don't remember the value, to be very honest, but it is very
But roughly
is 1/5 or 1/10 of. That is the reason people do it. But then doing a DRCG is a very tedious process. What happens is in any busy nuclear medicine department, if you send a patient for a DRCG, this is a protocol wherein the child needs to void, and that urine splashes in the department. So for that particular day, no scan can take place. So people do not. That is a technical problem. So it is something like you are operating on a seropositive patient. You want to do it on as a last patient of your day. So that becomes a very difficult. That is why people do not. It is not very popular. But then we have done it, and then
another. Can I make another question? See, for transplant donor evaluation, we routinely do radionuclide renogram to assess the split GFR. So, what should be your ideal agent?
No, it is a DTPA. But as I told you, assessment of GFR, it is not the scan. It is the plasma sample method.
So we should advise. We should request for a plasma sample method.
If you advise, I promise I will buy that instrument in my department because it is hardly 15 lakhs. It is hardly 15 lakhs. Only thing is, it is cumbersome. We will need one technical staff for it. It is a difficult task for us. But if we get enough number of patients, we will do it. And it should be done. In a proper program, that should be the ideal one. You do
otherwise, it does not correlate.
No, it does not correlate.
Sir, another question from
a lot of time you are getting a normal creatinine, all other things are normal, but your DTPA reports are not matching.
Sir, another question from Dr. Yusuf from Arjigar. Sir, according to you, how long after a pyeloplasty surgery we should do a renogram?
Oh, there is no such standard this thing. I think you as a clinician know it better, but at least 3 months, if not 6.
Yeah.
Sir, Dr. Navankur Ghosh has come up with another question. Is any gap between required between two radioisotope scans like FDG PET and DTPA?
FDG PET and DTPA, FDG, they're two different indications altogether, but then minimum 1 day gap, because what happens is if we do DTPA first, then we can do the FDG the very next day, because you know the DTPA, the isotope is gamma emitting, which is a low energy. So even if we do FDG PET next day, that is a high energy positron. So this will not interfere in the scanning. But if we do the FDG first day, then we want to do the DTPA next day, there may be some problem, but that is too theoretical. There is no such. We can keep 1 day gap and we can do either of them.
Sir, Dr. Hashan has asked, sir, what is the creatinine level above which DTPA is dubious?
It depends on lab to lab. If the creatinine is abnormal, then DTPA will. In fact, a lot of time, if the creatinine is normal, we get to see not good clearance, because you know by the time GFR reduction of GFR is earlier than the creatinine rise. So, but then if the creatinine is really high, then the DTPA scan is not nice and the results will be dubious. But because if the kidneys do not take up the radioisotope properly, then the confidence about commenting on the drainage is always limited. That is why we prefer doing EC or MAC3 in a raised creatinine setup.
Sir, you have already answered this Dr. Shyam Sarkar's question. Minimum time period following CECT when DTPA can be done.
Minimum time period as per theory is 10 days, provided the patient really follows a strict instruction of hydration. But sometimes we have seen even after 15 days, the scan quality is not great. My personal experience is I have seen people undergoing a CECT study even after 15 days. If they have not followed good hydration protocol, then the scan is not fine. That's why we say 10 days because it is written in the textbook. I generally talk to the clinician and patient. If it is not urgent, then delay it by 2 weeks.
Sir, another new question. Sir, can we get NORA value and cortical transit time from DTPA scan?
Yes, we can, but then these are vendor-specific softwares. These were published around in the year 2010 or something. These NORA and then cortical transit. You know all these values. I mean, some company had done some studies, and many papers were published with NORA, but then they're not. Honestly speaking, they do not hold much in the clinical practice.
Can I
Any
ask
more
a
questions? Yes, sir. Sir, Tomo sir, our secretary has some questions.
Yes.
Okay. Most of the times, lot of the times, we have a almighty kidney with some part is very much hydronephrotic, other part is refluxing. What should be the ideal technique for diagnosing the function of each part?
Again, when we are talking about renogram, EC is best, if not the DTPA. Normal dynamic renogram or either using EC or DTPA, EC is preferable. If it is a duplicate, you see there could be so many situations. One is a duplicate, both the moieties are clearing normally. That is one. One is duplicate, one of the moieties are obstructed and not clearing. And another is, I think what you are suggesting is one moiety is non-functional with the reflux. We commonly see a yo-yo reflux when the one moiety is clearing, suddenly the isotope goes into the non-functioning moiety. It is seen both in DTPA and EC scan. So, but then preferably EC, but you can do it DTPA also in another population if the creatinine is not.
The value of the cortical function in those cases, can those be reliable? What I mean to say, when I'm assessing the GFR rate, the GFR rates that comes out, are those reliable in these cases?
In duple moiety?
Yes, yes.
Yeah, fairly. This is just like, for example, you are imagining like left hydronephrosis and right normal duplicate kidney. But then again, if you really want to see the cortical functions, because we see a lot of prescriptions, DTPA, DMSA together. So,
sir, another question is from Dr. Saurabh Jha. Is T half time is sensitive enough to say obstruction if curves are type 3B or 4?
No. I mean, honestly speaking, these are too theoretical. Every text, because when you are writing a paper, we do write about, we do, rely on a lot of objective parameters, because all of us know that when we are writing a thesis or an academic paper, so these things are, T half is so much, not in any scan, trust me, even when you were reading a CT scan, we talk about Hounsfield units. All of you know HU so much, HU so much. But what at the end matters is somebody looking at the scan and interpreting it. All these values are adjunct values. They are generated by the computer systems and quite variable in terms of interpersonal, usage. So T half, we never mention T half. It comes automatically in the report. Anybody, but then I understand that a lot of time people want to write a paper, they will need some objective parameter. Otherwise, in clinical practice, no.
What should we order for transplant recipients? As you said, DTPA is not sensitive enough.
No, it is DTPA only. It is the DTPA plasma sample method for a correct assessment of GFR. Along with a DTPA scan, if you want to see the split functions, because split function, how will you get unless you image them? Because DTPA plasma sample is just a blood test.
Any more questions? It's a nice interactive session.
Thank you so much.
I request our secretary, Dr. Soumya Mondal, to make a concluding remarks.
I really thank Dr. Deepanjan Mitra for joining us today. This program is practically scheduled to meet our needs of our society. The residents, the residence programs will help much from it. Not only that, this renogram is needed so much in our day-to-day practice, and we have so many confusions regarding it. I hope today's cast must have taken care of much of the confusions over there, and the residents who have really joined have really helpful. And finally, I again thank Dr. Deepanjan Mitra for joining us, for taking his time, and really ask him to join him in our future endeavors, and if any taken in our future time. Thank you, Dr.
Thank
Deepanjan.
you so much. I really enjoyed it. Thanks everybody for
We'll
listening.
take
Prasanna, sir.
again his help to learn about PSMA PET
Yes,
someday.
sir, my pleasure. So my next
Thank
slides were there, but then it will take another half an hour. So
Right.
maybe some other day.
Sure. Thank you.
Thank you, sir. Thank you, everyone, for joining
Thank
this
you very
session.
much.
Thank you, Dr. Shashi. Thanks. Bye.
তোমাকে এই শার্টটা নেবে
Okay, sir.
আচ্ছা শশী,
हाँ, sir.
ইয়ে আউট হয়ে গেছে নীলাঞ্জন?